So metabolic side effects, these are very common. Weight gain is significant. I have, just personally, I've seen 50 and 60 pound weight gains. But usually you're talking about more in the 10 kilo. So very significant. And often that then leads to type 2 diabetes in people who are at risk and people who are not at risk. So looking at which of the drugs are more likely to cause weight gain is important, because if you've got people who are already at risk for type 2 diabetes or have pre-diabetes, then they will almost definitely go on to have those metabolic problems. So hyperglycemia, hyperlipidemia, hypertension. So you can see where cardiovascular risk goes up significantly when people take these drugs. I'll ask Dr. Britton, but I can tell you that when I did diabetes, a significant number of patients that I saw were diabetes secondary to the second generation antipsychotics. It was a big referral to our clinic, so we saw quite a few. Weight gain, monitor at every visit. Warn the patients. Drugs with the highest risk are olanzapine, quetiapine, and risperidone. The lowest are aripiprazole, that's Abilify, and ziprasidone or Geodon. Weight gain can be rapid in the first few months, ranging from 0.5 to 5 kilos over 10 weeks. Now you think about that. 5 kilos is over 10 pounds, so that is a pound a week. That's a lot. That's 3,500 calories extra a week. Okay? So about 500 calories extra a day. So interventions switch from a higher risk to a lower risk. Assess the diabetes risk for these patients and choose the lower risk if you have an option. Or if you've got somebody who's rapidly gaining weight and they're showing signs of high blood sugars, then if you have the ability to switch them to a lower, that would be great. Yes?
Is it that they're eating more, or is it that they're just retaining what they eat?
I don't know the underlying, some of it comes in with insulin production.
Okay.
So it's really not, it's not something they can necessarily forestall unless they do something about it. And I'm going to talk to you about some studies at the bottom of interventions. Okay. So behavioral weight loss. So studies have been done and looked at enrolling people in behavioral interventions to try and reduce the risk of progressing on to diabetes. So they found that they tailored what the patient they tailored the intervention to the patient. That seemed to be very successful. They did exercise, in some of the studies did group exercise. They gave them incentives, so either money or cards or something that would incentivize them to come. Greater proportion of patients lost 5% or more body weight. That's significant compared to control. So that worked. So an intervention worked. The STRIDE was a well-done weight loss and lifestyle intervention. They did weekly interventions for 6 months. And then monthly for 6 months. They did education and skills and behavioral self-training. So what to choose to eat, how to eat. Increasing awareness by monitoring, self-monitoring of diet monitoring during the visits, physical activities, and sleep over time. I don't know what I meant by that now. I have to think about that. I haven't looked at that for a while. Personalized, again, they personalized the plan, modified diet, reduced calories, increased physical activity. That also seemed to have, was significant. Okay, so outcomes, intervention patients lost more weight, had lower blood sugars at 6 and 12 months. So that's pretty good for an intervention study out that far. Another drug that has been looked at, and we'll again talk about this quite a bit when we get to endo, is metformin. So metformin is the first drug of choice. We use it in prediabetes. It's the drug of choice initial therapy for diabetes. That also seems to be helpful in helping them lose weight. It's not intended for that. It really doesn't have a mechanism for that. It's considered more weight neutral, doesn't cause weight gain, doesn't cause weight loss for a majority of people. So they say at most trials, recent weight gain found at 12 and 16 weeks of metformin led to a loss of approximately 50% of the weight that had been gained. So somewhere in that 1 gram to 2 grams a day. That's about in the range we use to treat diabetes as well. So star that. That is important. It really is important. The weight gain with those drugs is amazing. It's tremendous. And their risk of diabetes is really high. Okay? If they get diabetes, we treat them just like we would somebody who didn't have a drug-induced. So hyperglycemia, people with schizophrenia, just having schizophrenia puts you at higher risk for diabetes. I don't know why, but it's a disease that's associated with type 2. Risk factors for diabetes plus the use of the second generation greatly increases the risk. So we haven't talked about risk for diabetes, but it is being overweight, having a BMI greater than 25 or greater, having a first generation or first degree relative. So your mother, your dad, your siblings that also have type 2. So it has a high genetic component. Other things that are associated with it is if you're a female and you've given birth to a baby over 9 pounds, if you have hypertension, if you have dyslipidemia, if you're a woman and you have a history of PCOS, those are common risk factors for the development of diabetes. And we'll go over those more. We will go over those a lot when we get to endo. So in 2004, so almost 15 years ago, the FDA put a warning in there about the increased risk of hyperglycemia and diabetes. Greatest is with olanzapine and clozapine. Intermediate risk, risperidone and quetiapine. Lowest with ziprisidone, which is Geodon, and aripiprazole, which is Abilify. Doesn't mean they won't get it, just means the risk is lower. So the monitoring guidelines that came out in 2004 when initiating these agents is a baseline weight and BMI, blood pressure, fasting lipids, and ask about the history of diabetes in the family. If somebody's parent has type 2, you have a 50% risk of having it. If both of your parents had it, you have an 80%. It's a very high genetic component. Okay. Frequently monitored. So I told you about the screening for metabolic orders or disorders now that Medicare requires. They're listed there. So they must document the BMI, the blood pressure, the blood sugar, lipid status in the past year for patients who are discharged with a prescription for an antipsychotic. So they have to submit that data. If they don't, if they're non-compliant, then it affects their reimbursement. So they've got them. So using a lower SGA, we talked about that. Younger patients seem to be at more risk, higher risk. The other thing these drugs do is atypically they will cause diabetic ketoacidosis. So sometimes we usually associate DKA or diabetic ketoacidosis with type 1. The symptoms are listed over there. Rapid onset, polyuria, polydipsia, weight loss, nausea, vomiting, dehydration, rapid respiration, and coma. It's a metabolic acidosis due to the great production of ketones. Ketones come from rapid fat breakdown because insulin doesn't exert its effect on adipose tissue. Okay. So DKA is a life-threatening situation. People can die of it. It makes them very sick. It's unusual to see a type 2 present like that, but people on second-generation these second-generation agents, sometimes that's the way they'll present. I have seen it with most of the older second generation, that was the presentation. Okay. Maybe their first inclination that they have diabetes, before these guidelines came out and these monitoring compliance things that they had to do, patients would be on these drugs and nobody's looking at it. You know, if they're only going to the psychiatrist and no one's monitoring their metabolic baseline, then these things can happen without them being aware. Treatment of diabetes is the same. We'll talk about that more, so it's nothing unusual that we do. Hyperlipidemia, we do the same thing. We'd assess the risk, and then we would treat them. Usually a statin would be still the drug of choice. Hypertension, we would treat them according to guidelines. So once they've got it, we treat them like we do everybody else. The big thing is try to prevent. Common. I cannot tell you. You might as well start. I will ask you about these. It just happens to a lot of the patients, so be sure you pay attention to those. Myocarditis and cardiomyopathy. This is more with clozapine. So clozapine is a very effective drug. It is a very toxic drug. We're going to talk about it kind of in its own category because it has some agranulocytosis that can cause death as well. So these fatal cases of myocarditis and cardiomyopathy have been associated with clozapine. If you use clozapine, you have to take a test, you have to show that you know what you're doing, and if you're a pharmacy, you have to sign up. You have to ensure that patients have had the blood, no drug. That's the little moniker they have with this. So it's a heavily regulated drug because of the side effects, and because many of them are life-threatening. But a good drug, if none of the rest work, it's a very effective drug. Orthostatic hypotension, well, because of that alpha adrenergic blockade, then they tend to get orthostatic. An orthostatic tachycardia, so what's that mean? Stand up, heart rate goes up, okay. You see it early on, most frequently observed with clozapine. Iloperidone, that is Fana, is the name of that one. Quetiapine and paliperidone. But you can see it with most of them. These have the most alpha adrenergic activity. Most of the time patients do tolerate it, but in those who have blood pressure and problems, pay attention to that, because you may have them on other drugs that aggravate or work against that. Increased risk of mortality. Okay, this goes back to what I was telling you, is that these drugs, regardless of baseline, increases the risk of mortality. Again, people are beginning to think it's due to cardiovascular risk, metabolic problems that are associated. But it's across the board. All types of mortality are considered to be increased. So the ones, if you look down in that third bullet, specific cause of death, cardiac disorders, 25%. Cerebral vascular disease, 8%. Pulmonary disease, 8%. Cancer, up 7%. Diabetes, 3%. So it goes with both the first and the second generation agents. First generations may have a little bit more higher mortality associated with them than with the second, but it's considered for both groups. Sexual side effects. So a lot of these drugs are going to cause sexual dysfunction like we saw with the antidepressants. All phases, libido, arousal, orgasm, all of them. It can be due to a loss of desire because of the dopaminergic inhibition. Reward pathways have been blunted. Erectile dysfunction because of the alpha adrenergic blockade. Anticholinergic activity, impairment of desire, arousal, and orgasm due to elevated prolactin levels. So one of the things to always check if a patient's complaining, so this would be one thing to always ask them about. And if they're having a lot of sexual dysfunction and other symptoms, and I'll show you those in a minute, then measuring a prolactin level would be important, because dopamine may be disinhibiting that release of prolactin from the pituitary gland. So page 9, 60 to 70% of patients taking paliperidone or risperidone had sexual side effects. 50 to 60% with olanzapine, quetiapine, ziprasidone. Now, I don't care so much that you know the percents. What I think is takeaway, it's a lot of the people, okay? So it needs to be part of you asking. They may not bring it up, especially a male to a female, they may not tell you. Women may not tell anybody. So ask directly about them. So if they have sexual dysfunction, then moving down to Abilify, that aripiprazole is the least of the group. The other is measure a prolactin level. So let's go down to that section. So prolactin secretion is controlled by the inhibitory effects of dopamine. So if you inhibit dopamine, then prolactin levels can rise. Clinical consequences of those. One would be gynecomastia. So I don't know if women would complain, they may not so much, but males would complain. Okay. Galactorrhea, what is that? Secretion of milk. So if they start telling you, I'm leaking milk from my breast, and they're not breastfeeding, that's not a good sign. So that would be, think prolactin. Menstrual disturbances. Let's say there have been regular or their flow changes, then looking for that. They become amenorrheic or they develop very heavy blood flow. That would be a time to check. Complaints of sexual dysfunction, infertility. Okay, so prolactin is going to suppress their FSH release. Okay, so the ones most strongly associated with this are risperidone and paliperidone. Risperidone, look at it. It also increases the risk of pituitary adenomas. So the next part talks about frequent asking and then also checking prolactin level. Comments or questions about those? Anticholinergic side effects. You should be well versed in these. So the dry mouth and constipation tend to be more of the problem than blurred vision or urinary retention. The only difference is with clozapine and sialorrhea, so they just produce too much saliva rather than dry mouth, and it's due to the effects of the D4 and the alpha-2A. Let's see, anything else on that? It's recommended that you aggressively treat the constipation so they don't get fecal impaction, especially if you're dealing with older patients. So the use of the things we talked about, laxatives, regular bowel habits, fiber in the diet, probably won't be enough. They may need a medication like Miralax, an osmotic agent to help with to pass stools. Sedation. So sedation is a common problem. We talked about the effects on histamine. Usually is early. A lot of times if it's mild to moderate, they will develop a tolerance to it. And it won't bother them anymore, but early on it may. So be sure and warn them, especially if they're driving or need to be alert at certain times of the day. That would be a problem. So most prominent with clozapine and quetiapine in up to 50% of people. Abilify has the least, and people may even complain of insomnia. So ask about sleep disturbances. Don't just go with the sedation. Also ask about other impairments of sleep. Falls. So the FDA issued a warning last year that these drugs can increase the risk of falls and fractures. And that's because of the increase in sedation, also the orthostasis, and motor and sensory instability. So they recommend that you do a falls assessment. Now, have you had a module yet where you all have talked about fall risk assessment? Okay. We will, I know Dr. Britton does it in geriatrics. We will also do it in in the women's health module, when we talk about osteoporosis, we will talk about how to do a fall risk assessment. So your older people, but even those who are younger who are at risk, it's usually looking at, do they have other drugs that would increase their risk of falls? It's having them do a vision. If their vision is poor and hasn't been corrected, then having that addressed. The home. Do they have things in the home like scatter rugs or things that people would fall over? That's really important to do. And is it occupational therapists? You can actually have people come in and assess the home for risk.
The OT will go in and they'll look at everything about the way the house is laid out and how the person living in it does things, and they'll make suggestions.
You want to say anything else about fall risk that I didn't add?
Not really, because you've covered the good part about risk. The rest of it, you kind of need to get into your musculoskeletal and other modules to have some background to do it. Okay.
So from a primary care perspective, a lot of this will fall on you. When patients see a psychiatrist, they see them and they're out. They may spend 15 minutes with them, if that much. They ask them if they're having any trouble, if they need anything, they write the prescription, they're out the door. So you assessing these as a geriatric person, primary care person, this would be important. So don't shirk it, not shirk it, but don't ignore it because it wasn't a drug you started. Because it certainly, a lot of the things that come up will fall in your realm if you are family medicine or internal medicine. Neuroleptic malignant syndrome. So this is a more severe, this is an emergency type like we talked about with the serotonin syndrome. If you look at the bottom, you'll see the differences. You see the rigid muscle tone, the increase in mucosal secretions, pupils normal, bowel sounds go down, reflexes go down, so different. Medical emergency, they can die from this, so it's important that it be paid attention to. All of them can cause it. The most strong predictive of having a neuroleptic or a neuromalignant syndrome is they've had it before. Okay. So getting a history. It will also occur when therapy is started or when you're aggressively moving the dose up or titrating it up. If they've had parenteral administration, so IM would be the more common, or they've had an illness that has debilitated them, or they're dehydrated. Okay. So those are the at-risk. And those need emergency room treatment. Seizures. So all of these drugs will carry a warning about seizures. There's little evidence that they cause seizures, but they may lower the seizure threshold. So if used with other drugs that do that, there could be an increased risk. Clozapine is a 3% risk. So the risk is low, but you will see it on all of the medication. Risperidone seems to have a higher than others. It's rare. So clozapine, there is a caution that using it in patients who have seizure disorders, consulting a neurologist with patients who have known seizure disorders if you're concerned about that risk. Cataracts. Okay, again, there is warnings on these drugs about increased risk of cataracts. Quetiapine, in particular, recommends that patients undergo a slit lamp exam every 6 months. And then ocular exams are recommended every 2 years in younger patients. The first generation agents tend to cause more problems with the eyes than the second, and I'll show you some pictures when we get over there. Agranulocytosis, the bone marrow effects are mostly with clozapine. Think agranulocytosis when you think clozapine. It can be a fatal condition. It occurs early on, particularly if people have low counts to start with, even if they're in the normal range. Most countries regulate the use of clozapine because of that agranulocytosis. And you have certain monitoring that you're required to do if you are prescribing it. let's go down to that last bullet. So it's recommended that you don't, let's see, where is that? It's like 1,500. Oh, I know, I've got a separate section on Clozaril, so I'll talk about it there. So the monitoring is an ANC, so an absolute neutrophil count at baseline at 1 and 2 weeks, and then every 3 to 6 months. So it's a great drug. It is better than, in some regards, than the others, but it does require frequent blood draws and frequent monitoring. The hypersensitivity, have you talked about DRESS? Okay, so the second generation are agents that can do that. Clozaril or Clozapine is probably the most common to do that, and as is Ziprasidone, which is Geodon. I recently saw, I didn't get the details down, it just kind of something that went by as I was looking at different updates, that they may be applying this to more of the agents in this category, is this hypersensitivity syndrome. Can be fatal, so keeping it in mind as a possibility is important. So it's eosinophilia and systemic symptoms. I think DRESS falls as a type, is it type 4? Okay, type 4. Okay, Clozaril, let's talk about it. Neutropenia, life-threatening agranulocytosis. So the FDA requires that the patient have an absolute neutrophil count of 1,500 per microliter or greater. So commit that one to memory. Requires regular monitoring. There is a registry that the patients have to sign into. There's a single one. It's called the Clozaril Risk Evaluation and Mitigation Strategy, or RIMS program. So clinicians have to be registered, pharmacies have to be registered and certified. So the patient gets the weekly to monthly monitoring to maintain that ANC at 1,500 or above. Let's see if there's anything else. I think we've hit most of it. The other is just the reminder about the myocarditis with Clozaril. It's reported anywhere from 1 in 500 to 1 in 10,000. So different case reports give different incidents. So early on in therapy, monitor for signs of myocarditis. The lab that can be included would be eosinophil count, sed rate, C-protein, C-reactive protein, or the troponins. Other severe adverse effects of Clozaril are listed there. So PE, diabetes, DKA, seizures, adynamic ileus. So this is always going to be a second line. It has low risk of EPS. It has some really good things that the other ones don't. It has some side effects that the others, or it has some of the side effects that the second generation Clozaril doesn't have. But it can have some lethal consequences. So if you're involved in its use, you'll be aware because you will have to be certified to do that. Questions about that?
What was the last side effect you said?
Okay, so ileus is what? Gut.
Go ahead.
Gut.
You're illegal.
So the gut just stops, so it doesn't work. There's no peristalsis. So it makes them really sick. Side effect profile of the first generation, most of these are going to be similar. There are some differences, so we'll hit the differences. The metabolic syndrome can occur with them as well. Chlorpromazine, which is Thorazine, carries a fairly high risk. Some of them are lower, and you can see by that first chart that I gave you that weight is highest with the earliest, the chlorpromazine and the thyroridazine, and it's lower for the older or the newer agents in that group. Okay, think QT prolongation and sudden death. This is the first generation. Thioridazine is the big offender in this group. Do not use that as a starting. That one's Meloril. It's one of the oldest of the agents on the market. Also is associated with IV haloperidol. They really recommend you don't give it IV, that it's give it IM instead, and Pemazide if it's used when a 3A4 inhibitor is in place. Don't use Meloril as a first-line treatment. Prior to baseline, if you're going to use a first generation, or if thioridazine comes into the mix, is an EKG, and check it annually when you change the dose or the patient's cardiac status changes. Serum potassium, always think potassium and magnesium in preventing or decreasing proarrhythmic potential. So in terms of drug initiation, don't initiate if the QTc is greater than 450 milliseconds, or if there is a change in over baseline of 60 milliseconds. Okay, so significant risk of torsades. Avoid using inhibitors of 2CD. Remember, most of those drugs are going through that enzyme system. For other first-generation agents, monitor the EKG, potassium, magnesium. So QTc, much more common with the first-generation, thioridazine, the worst in the group, or the most impactful. Orthostatic hypotension is more common with the first generation, especially thioridazine and chlorpromazine. Those are the oldest of the group. Alpha-adrenergic blockade, orthostatic tachycardia like we talked before. Lower the dose, lower the titration. Risk of mortality on the next page is the same as we talked about the second, so you can just write the same. Sexual dysfunction, same. They all increase the risk of sexual dysfunction. Haloperidol, one of the highest. Prolactin, they all will elevate prolactin, so write same over there to the side. Here, the anticholinergic, they will vary just like they do with the second generation. So it depends on how much of they interact with the muscarinic receptor. So chlorpromazine, thioridazine, the older agents. Dry mouth and constipation, more of the problem than blurred vision or urinary retention. Again, adjusting dose, look for other drugs that are also anticholinergic. I told you when we talked about this before, when I look at people's regimens and there's multiple drugs, I can usually in older people find multiple drugs that have anticholinergic effect. So they all add up. So if they're complaining of constipation or those kinds of symptoms, look for different drugs that could do that. Sedation, mostly the chlorpromazine again and thioridazine, so you can see it with the first. Falls, they have the same warning that we saw with the others. Neuroleptic malignant syndrome on the next page, same thing. Seizures, they carry the same manufacturer warning. Now ocular is different, so make a little star over there. Here's a difference. These drugs can cause a pigmentary retinopathy. So you can see the deposits in the lens and the cornea. So the phenothiazines carry the highest risk. So this is those early agents. So that's where the recommendation comes to have an eye exam every 2 years, up to age 40, and then annually thereafter. The other ocular issues are not that common, but keep that one in mind about the pigmentary retinopathy. Next page, agranulocytosis can occur, but to a much less extent than you would see with the Clozapine, and cholestatic jaundice is more associated with chlorpromazine. That's about it for all those side effects. Now we move on to the more distressful ones, are the EPS and the tardive dyskinesias. I have videos on these. I did not load them into anything that I brought with me, so I will post some for you to look at so that you can look at these different types. We've talked about these with other drug classes, but these drugs carry high risk. And the problem is some of them are reversible, but they're distressing to the patient. But the tardive dyskinesia can be permanent, and they're very distressing to those who are the family and to the patient. Okay. So the EPS are the akathisias, Parkinsonism, and dystonias. Okay, so we talked about some of these when we talked about Parkinson. Very common, the akathisias, going down there, feeling of restlessness. They just can't sit down. They have to keep moving, fidgeting, pacing. So we can use benzodiazepines or a beta blocker to treat them. Parkinsonism, that is a problem. Usually it's low grade. Often patients can tolerate it. But they can have more of the resting tremor can be significant, the cogwheel rigidity, the gait can be worsened, psychomotor retardation. So it can worsen an underlying problem or it can be new onset. If it is disabling, they recommend using benztropine, which is an anticholinergic. If they can't tolerate that, then using amantadine. The dystonia, so there's pictures here of the different types, the torticollis, the retrocollis, the ocular gyrate crisis, and opisthotonus. Have you told them your story about your torticollis? Okay.
I actually acted out just a little bit.
It's so distressing looking. It really is. I did see, I told you that I saw the opisthotonus in the ER one time. A young woman came in. She had gone home with a guy, and he strangled her and cut off enough of her airway, damaged her airway, but they found her before she died, brought her in, but this is what she looked like when we walked in the ER. She had that opisthotonus. It was, she made it. So there was a good outcome, but it was really bad in the beginning, and she had that very, very same posture. Severe dystonias, the benztropine or diphenhydramine, very common, IV, it just like that. When Dr. Burton was laying there and all that contortion and stuff, as soon as that Benadryl went in, normal. It's impressive. Did it feel that way?
I could tell, I watched it come down the line, and as soon as it went in, it was like that. I mean, it wasn't even a delay. I could just immediately feel better.
Yeah.
So that tells you drugs are doing it. Hurry.
So the difference between the first and the second is the higher incidence of the akathisias. If you look at the bottom, rigidity, the bradykiniasias, tremors, acute dystonic reactions, EPS, more common with first. That's why people have moved on to the second. The high potency, flufenazine, haloperidol, which we still use, loxapine, pimozide, thiofixine, these have the highest risk. So we don't use them as much, but you may still see them in play. The low potency, like those first two, chlorpromazine and thioridazine, less likely because they're not as potent. So you should ask patients about onset of these. Have you talked about the different tools you can use to assess these? Have y'all covered that? Okay, let me see if I can. Why does this stop? So there is a scale called the Abnormal Involuntary Movement Scale. Can you read some of it? Let's see if I can do that. Let's see. Okay, so on this one, the very first are facial and oral movement. So it asks muscles of facial expression, lips and oral area, jaws, This might be something that the doctor fills out, or the physician or the provider, when they're looking at them, and it looks at the date, and then they can do a scale of 0 to 4. So that might be something that could be used to compare. So it's got extremity movements, trunk movements. There is another one. Let's see if I can... This is the brief psychiatric rating scale. It's more general, and it covers a lot more different things like somatic concerns, anxiety, emotional withdrawal. You get down here, it's mannering and posturing, grandiosity, so some of their thoughts, hostility, hallucinatory behavior, how cooperative they are, unusual thought content, covers more than just the movement. But these are different scales that you could use as a provider that you can compare then and see where the differences are between visits. I will post those. I didn't put them up on the D2L, but I'll post them for you to have if you'd like. Okay. Tardive dyskinesias, and I'll post some videos on these. These are very distressing. They're chorioathetoid movements, so it can be any part of the body. So tongue is common. They'll just push their tongue out constantly. And they're not even aware, or they're grimacing, and it's a repetitive grimace or movement of part of the body. Lip smacking, I've seen a lot. Jaw movements, facial grimacing, extremity writhing. Dr. Britton, you want to make any comment on those? I've seen most of the ones I've seen are facial. But they're permanent. You cannot reverse them once they get into place. So the biggest thing is avoid them. The only way to avoid them is don't use an antipsychotic. But if you have to use them, using smaller doses, watching for them to occur. So being aware of what they look like, because the patient may not be aware, or they may, or the family members may tell you about them. And then instituting treatment can help decrease that, but they're disfiguring. They put up barriers between them and other people. So it's really important to have a high awareness and evaluate. So the cumulative for the first generation is about 5% a year. So the longer they are on these agents, the more likely they occur. That's why people have moved away to them. The low potency, so chlorpromazine, thyroxine, not so much the problem. It's those high potency ones that are at the bottom of that list. So evaluate them when you see them. Hopefully the psychiatrist is too, but again, they are very quickly seen. You as a primary care person do that as well. And there's that abnormal involuntary movement scale is the one I showed you. For some reason, I cut and pasted the same stuff twice, so the bottom of that page is a repeat. So if you'll look over on the next page, if you can move them to an agent that is less likely to cause it, you could do that. If you could get rid of the drug, that would be great, but most of the time that's probably not going to be a cause or a thing that you could do. The other is look for other drugs that could also be adding to it. Metoclopramide would be one. It can also cause a tardive dyskinesia. So avoiding drugs that have multiple methods to cause a tardive dyskinesia.